So good evening or good afternoon. It's my huge pleasure to introduce this webinar, SPR webinar for Ukraine. This is an initiative that SPR, under the head of the European chapter, has initiated several months ago, of course, in the context of the Russian attack on Ukraine to support our dear colleagues in Ukraine, psychotherapists and psychotherapy researchers who who are here with us here and for whom we do this webinar to spread information about psychotherapy and psychotherapy research that we think and our small group thinks could be interesting. So this is our way to stand with Ukraine. This is our way to support the Ukrainian people in this, we realize still ongoing and very difficult situation of attack on your country. So with all respect to all this situation you're experiencing, continuing to experience, I don't want to take more time before we want to introduce our two speakers of this afternoon. I also want to welcome a few colleagues of SPR supporting this initiative here today with us, with Michal Milimeka from Poland and myself, Uli Kramer from Switzerland. I would like to give 2 minutes to Katarina for a few information on translation, please.
Дякую, Елі. Вітаю всіх, раді вас бачити. Отже, якщо хто не бачив повідомлення у чаті, ще не знайшов, якщо хтось не бачив повідомлення в чаті, ще не знайшов, як перемкнутися на український переклад, вам треба, якщо ви на телефоні, знайти значок 3 крапочками вверху екрану, натиснути його, і там випаде меню, де ви обираєте меню планетки, і там обираєте український канал. Якщо ви з ПК, з комп'ютера, то цей значок ви можете побачити внизу панелі під всіми віконечками. Так само натискаєте на нього і обираєте український канал. Якщо ви хочете слухати англійською мовою, то не обираєте нічого, залишаєтеся в оригінальному каналі. І хочу сказати, що буде доступний запис цієї лекції обома мовами, і англійською, і з українським перекладом. Отже, якщо ви не знаєте, що обрати, ви зможете послухати потім тією мовою, яку не обрали сьогодні. Бажаю всім плідної лекції і передаю слово нашим організаторам і спікерам.
Okay, thank you, Katarina. Let me thank warmly Anastasia here for your wonderful interpretation. It's been so delightful just to listen in Ukrainian by Katarina. Now I understood it, everything. It's wonderful. So let me go directly to our two speakers. With no further ado, it's my huge honor and pleasure to introduce Hadas Wiseman from Haifa University in Israel, and Jeanne Watson, who is at the University of Toronto in Canada. And they will be speaking this evening in Kiev on the responsive psychotherapist, how therapists from different approaches attune to their clients in the moment. So we do have a little bit more than 1 hour until 6:30 or 7:30, excuse me, Kiev time. So I hand it over to both of you, Jeanne and Hadas, please.
Thank you, Uli. I'm just going to share my screen. Hopefully everyone can see that, correct? Good. Okay. So hello and welcome, everybody. We're really, really pleased to be here with you today to talk about therapist responsiveness and share some of these ideas with you, especially during these very, very challenging times. So your attendance here today is a great honor and very, very special. So as Uli mentioned, we'll be talking about the responsive therapist attuning to clients in the moment. There we are. The talk is drawn directly from a book that was edited by Hadas Wiseman and me, the responsive psychotherapist. It was an edited text that we developed as in an attempt to get the different research clinicians from different approaches to try to begin to explicate what guides them in the session, and what are the cues that they attend to be more responsive to their clients. So as we start, it's good to think about what is responsiveness, right? Bill Stiles has defined responsiveness as behavior that is influenced by emerging contexts. He differentiates between what he calls appropriate responsiveness. So it's in psychotherapy, so it's kind of doing the right thing at the right time. And suggests that this implies a dynamic relationship between variables that involves bidirectional causation as well as feedback loops. Kramer and Stiles have both observed that responsiveness is an essential and ubiquitous characteristic of the therapist-client dialogue. There's no getting away from it. It's kind of built into the therapy. And this tailoring treatments to clients' cognitive and affective states in order to meet them where they're at different points in time makes a huge contribution to treatment outcomes, as we've seen in the outcome literature. So it's a very vital part of treatment effectiveness. However, it's also been observed, primarily by Hatcher and Stiles, among others, that responsiveness is a problem for psychotherapy researchers, especially treatment effectiveness studies and randomized controlled trials. They argue that protocols change as therapists tailor treatments to individual clients. They suggest that the mutual dependence and interdependence between client and therapist violates, the independence of the dependent and independent variables. They also argue that responsiveness has multiple impacts across multiple timescales. And these can, be microseconds to months and even years later, where the impact of some kind of intervention or response may actually be felt, or we can see its outcome. It also makes it very challenging to determine accurate dose-response relationships, and furthermore poses challenges for process outcome studies and determining accurate, meaningful correlations between the variables. Notwithstanding, there's still been an increased focus on responsiveness in the psychotherapy literature, especially with the work of Norcross and colleagues, who in their most recent edition of Psychotherapy Relationships that Work reviewed research on the effective elements of therapies. These were meta-analyses conducted, looking at specific variables and how relevant or important they were for the therapeutic relationship. And on the basis of these meta-analyses, they identified a number of client characteristics pre-therapy that are important for fitting treatments to particular individuals. And these elements, the effective elements that they identified, include clients' culture, clients' religion, and this included, Muslim, Christian, Jewish, as well as people with more psychospiritual, without any particular attachment to any one kind of orthodox religion. So it was sort of a very wide definition of religion, but nonetheless, religion too was found to, if therapists were attentive to clients' religion and found ways to help support them include aspects of their religion, including rituals or prayer, or in terms of their goals, it was very helpful. And the other client variable that they noted as being very important was patient preferences. There were some other pre-treatment characteristics or client characteristics that they thought were likely important, including clients' reactance level, how resistant, how reactive they are in therapy, their coping styles, their degree of readiness, or where they were at in terms of their stage of change, how willing or ready they were to actually engage in treatment and change, their attachment styles, their gender identity, and their sexual orientation. So these characteristics were thought to possibly be effective, but they thought that they needed more evidence. Okay. So, while responsiveness has proven to be problematic for researchers, it is certainly essential to practice as therapists, because therapists are continually adjusting and adapting treatments to their clients. And like the alliance, responsiveness is an integrative concept. It reaches across approaches and ways of doing therapy, and in fact can act as a sort of a unifying framework for how we research, conceptualize, and train psychotherapists. One way of thinking about the function of responsiveness in psychotherapy is to see it as both bridging to others and connecting with another, and transforming what is occurring in the interpersonal space and the interaction moment to moment in a session. And if we think of it like that, it's really a very sophisticated and a very complex type of responding that's vital to all approaches to ensure the effectiveness of treatments. Hatcher, when in his thinking about and writing about responsiveness, has suggested that there are two different models that seem to inform therapist responsiveness across different treatment approaches. The first model he characterizes as a two-person model, and the second one, he is one in which the therapist is sort of characterized or seen as the goal-directed agent in the therapy. And both these models sort of illuminate how therapists and treatment approaches try to balance their treatments with the client's needs, and also sort of highlight the focus of treatment. So what's the two-person model? In the two-person model, the therapist is focused on trying to understand the client. So their main objective in the therapy is to understand the client and the client's process in the session, in interaction with the therapist. The self is seen as socially constructed, with the family system as the crucible for learning and development. And the primary objective in this model is to provide more of a corrective relational and a corrective emotional experience for clients in the session. This model is holistic in its approach, and the approaches that are sort of informed by this model emphasize the role of empathy. They emphasize the role of therapists understanding in the change process. And typically, therapists in this type of model focus on clients' narratives. They focus on clients' emotions and emotional processing, as well as meaning making. Okay. In the second model, there's more emphasis on the therapist as the goal-directed agent. These approaches tend to be more structured. They're more linear and rule-based, and they have a very predetermined sequential kind of process that is followed. It's very much like treatment protocols. And here the therapists focus more in these type of models of trying to encourage or persuade or support clients to revise their behavior, their thinking, their emotions. So they're a little somewhat more didactic, I think, in how they interact with clients. The alliance, as well as clients' progress in these kind of treatments, are monitored at different time intervals along with treatment outcomes. It's those that feedback in terms of alliance or measures of treatment outcome that determine and guide and direct the treatment. These approaches, as I said, use more structured treatment protocols, and they tend to rely more on diagnostic markers to guide the treatment interventions. So if we look at responsiveness, what does it actually involve in therapy? Some of the qualities that we've identified that seem to be essential for optimal responsiveness include firstly, a technical mastery and an expertise. Responsive therapists show a strong sense of mastery of their theoretical models and their approaches. They're like expert skiers. They're no longer skiing on beginner slopes, but are really confidently swooshing down the mountain and meeting the challenges of the terrain, right? So they really kind of wear it well. They're an automatic pilot almost as they're operating. It's highly intuitive. Secondly, they've really honed their ability to attune and attend to their clients. They notice clients' nonverbal behavior. They really listen to what's being said, and they somehow are able to integrate all this information with what they know, with their theoretical approaches, with what they know about the client. Thirdly, they also demonstrate a quality of very alert curiosity and attention, and an exquisite sensitivity to the moment, as well as the whole. And their knowledge and understanding is contextualized within theoretical models, clients' histories, the problematic issues that clients are working on. They're very attentive to shifts and kind of perturbations in the alliance. And of course, they're highly competent in the delivery of specific techniques. And most importantly, they're constantly synthesizing. They're constantly synthesizing all this information and this knowledge across multiple timescales. So they're constantly updating their understanding of the clients and what people are working on, different sources, and feed all of this into their ongoing assessment of what the client needs now in the moment. And perhaps a lovely example of therapists' capacity to synthesize and draw on multiple sources of information is provided by the example that I'll share with you, shared with me by an experiential therapist. This therapist described the following process as she tried to find an optimal response in the moment with one of her clients towards the end of a very difficult session. She reported that she'd been working with this client for a number of years, and the person had experienced sexual abuse by a family member that had been covered up by the family because they occupied a prominent position in the community. So it wasn't acknowledged, and it was hidden, So in this session, the client was feeling particularly bad after an incident with a family member during the week. And the client was sharing just how alone and desperate and suicidal she was feeling, given the type of interaction she had with the family, given the way they treated her and her pain and injury. She described herself as, she said she felt like she was drowning in her despair. And this was, as I said, they were coming to the end of the session. So to formulate her response, the therapist drew on her very deep understanding of the client. And this was especially with respect to her sensitivity to any boundary violations. So she was very sensitive to the interpersonal distance between her and her therapist, between her and anybody, but in close relationships. And spontaneously, the therapist recalled a memory of teaching her children to swim in a lake when they were young. Right? The client has spoken about drowning in despair, and spontaneously this image came, and the therapist recalled that she had encouraged her children to swim independently by themselves while she swam nearby. And drawing on this image, she drew on this image to inform her response, saying to her client, sharing the image, that I have an image of swimming in a lake near you. And she asked the client if she could see her swimming nearby, and said that she was there if she needed her. The client in that session appeared very comforted by this response, and they were able to end and make an appointment for the following week. And the following week, the client reported how helpful the image had been for her in the session and throughout the week, that she'd been able to hold on to it, right? So it's a lovely example of a therapist spontaneously synthesizing all the information and drawing on her own personal experience in order to offer sort of an optimal response to the client at that point in time. So clearly, responsiveness is much more than adherence to treatment protocols or the correct and adequate implementation of specific technique. It requires a very sensitive, perceptive attention and a quality of listening that is alert to micro shifts in clients' moment-to-moment process to facilitate access to their unconscious, implicit knowledge that will provide opportunities for new learning to occur in therapy. As well, it's very important in order to for therapists to be able to work with clients from diverse backgrounds, diverse identities, right? Multiple intersecting identities, and clearly can enhance treatment outcomes so that the therapist can respond appropriately each moment. Okay, so then the question is, how do therapists attune? Horvath and Stiles called on the field to sort of identify the signals that therapists attend to. What guides therapists? What alerts them to be more responsive in a particular moment, right? So key, is therapists' capacity to attune in the moment that's optimal to or essential to their being responsiveness. It's essential to balancing the needs of clients, treatment procedures, techniques, as well as process variables. So one of our objectives was to access therapists' maybe unconscious, implicit knowledge and begin to map some of the signals to which they attend in the moment as they try to be optimally responsive in the moment. So we asked therapists from different approaches, research clinicians, including psychodynamic, cognitive-behavioural, dialectical behavioural, integrative, narrative, family, and emotion-focused therapy to identify and describe specific signals that they attend to in the session to guide their responsiveness. So how do they attune? Because pre-treatment characteristics are clearly important, and we can use these to tailor our treatments to clients. We can be alert to including aspects of religion or be alert to culture and avoid microaggressions if possible. But there's also things that happen in the session that make us alert to and provide guidance. And what are those signals that we attend to? So on the basis of these chapters, we colligated a number of different signals across the different therapeutic approaches And we collected them under three headings: client signals, therapist signals, and interpersonal signals. So, you know, client signals refer to client's characteristics or things that are happening in the session. Therapist signals include things like their theoretical lens or their own characteristics. And of course, the interpersonal signals have to do with the quality of interaction in the moment. Okay, so I'm going to speak a little bit about, or share some of the client signals that we were able to identify. This map of signals is by no means comprehensive. I'm sure there are many more signals that therapists attend to that need to be kind of described and documented. But, and, you know, much of the information we kind of know, but it's the information is held, different parts of the information is held differently in different approaches. So one of the objectives really is to begin to think about a much more unifying framework, right, that actually pulls in all this information, all this knowledge from all the different approaches, so that all approaches can have access to it and perhaps use it to inform their therapies to improve them, right, as opposed to remaining kind of isolated. So that's one of the objectives in terms of trying to map the different signals that therapists attend to be responsive in the moment. So what are some of I will talk about the client signals and start the therapist signals, and then Hadas will talk about complete therapist signals and discuss therapist signals and implications for research and training. Okay, so what are some of the client signals that we colligated from all these different approaches? These include things like clients' relational maps, their self states and organizations, the emotional expression in the session, their level of self-understanding and understanding of their experience, some problematic behaviors that are displayed, as well as their non-verbal behaviors. So first off, clients' relational maps. So these relational maps inform therapist responses in a number of different treatments, for example, in psychodynamic and experiential approaches. And these maps are informed by clients' interpersonal behavior, their attachment experiences, their beliefs and expectations about relationships with themselves as well as others. And some of these approaches use these relational maps to actually construct individualized treatment plans. So, for example, Silverschutz uses the principles of control mastery theory to inform case-specific formulations to guide interpretations at different points in therapy. And they have preliminary evidence that, in fact, these case-specific formulations and interpretations contribute to better outcomes, but also clients feel much more supported and understood, and it's really good for the alliance. Another group who use this very sort of case-specific formulation is Uli Kramer and colleagues. They use plan analysis as developed by Franz Kasper to inform individualized case formulations when working with clients with personality disorders. And they too have some preliminary evidence of how these specific case formulations improve treatment outcomes and really try to understand the motives of the patients in treatment and in the relationship, and try to circumvent and obviate kind of more problematic behaviors. And this too has been found to be effective. Okay, another signal that is observed and noted by therapists and some different orientations and approaches are clients' self-states and self-organizations. Therapists wrote about it, watching or listening or being attentive to clients' self-states in the session. And these were kind of revealed when clients were defensive, or perhaps revealed in the dreams that they shared, and even in their dissociative states. And these self-states guide therapists in the moment. For example, Diamond and colleagues in their work with families wrote about attending to parents' defensiveness in the face of negative emotion expressed by their children in a session. And they use, noting parent defensiveness, they use it as a guide for when to push ahead with the treatment protocol or to draw back. So it really serves as a warning, a caution, and they listen to it and attend to it and change how they're interacting in the moment. Similarly, Tishby discusses the importance of clients' dreams and dissociative states to guide therapists in a relational psychodynamic therapy. Client self-organizations are very important, and therapists attend to these. And these are revealed in the statements that clients and the judgments that clients make about their experience and how they react to their emotional experiences. For example, very self-critical or self-blaming behavior or statements, or negative emotions of shame and failure act as signals for emotion-focused therapists and possibly Gestalt therapists to perhaps introduce or suggest to chair dialogues, right, to begin to work with that self-critical process. Working within a more integrative framework, Boswell and his colleagues use clients' expressions of self-striving as indicators or cues that clients may need more validation from them as therapists. They may require more self-verification in the moment. At these, when they register these signals, therapists try to promote client self-awareness as well as opportunities for new experiences, including working to promote more self-compassion or increased self-assertion or self-soothing behaviors. Emotional expression. Responsive therapists attune to clients' emotions, both positive and negative in the session. Right? Positive emotions are usually seen as an indication that things are going well, and so it's great feedback for a therapist that the momentum's good, clients are engaged, there's synchrony. However, I guess probably therapists too are also very attuned to clients' negative emotions, especially those that are revealed in clients' painful experiences, as well as clients' verbal and non-verbal behavior in the session. Signs of pain might include clients' verbal and non-verbal expressions of distress, maybe revealed in their sadness or fear or sense of vulnerability and helplessness. And in addition, therapists also attend to their own sense of resonance. So it's not just something they see or observe or hear in the session, but it's also something that they may actually resonate to and experience in their own bodies that sort of alerts them to pain in clients' narratives. So they also listen to the intensity with which clients express their emotions. They attend to shifts in emotions from sadness to anger or positive to negative, and use those moments as feedback in the sessions. Some therapists use emotion as a compass to very painful aspects of clients' experience, while others use it to assess warded off states of feelings and clients' and those states that clients might be avoiding or denying, and use it as information on how best to respond. For example, in dialectical behavior therapy, clients' affective states guide the application of different treatment models. Just as in emotion-focused therapy, clients' emotions guide therapists in terms of their moment-to-moment empathic responding, and is useful in terms of flagging the relevance of different tasks. Okay, clients' level of self-understanding and understanding of kind of what has happened to them, what their experience is. Responsive therapists speak about attending to shifts in clients' narratives and shifts in their understanding of themselves and others, right? So responsive therapists listen to whether, for one, in terms of assessing narratives, whether the stories are coherent and comprehensive. They tend to whether there is a sense of sameness, the same old story and what clients are sharing, or there's a sense of newness, something shifted, right? And these, the newness can be a micro shift, right? That somehow the client is seeing something a little differently than how they presented it before. An example of this is the work by Ribeiro and colleagues, who used the therapeutic collaboration model in narrative therapy. It can be used in different therapies, but they've used it in narrative therapy to assess clients' narratives and determine their kind of client's therapeutic zone of proximal development. And they used this information that they assess in clients' narratives to sort of make a decision to guide them about whether to be more challenging in the moment, or whether to step back and offer more supportive interventions, so that they work within clients' therapeutic zone of proximal development and don't sort of challenge them beyond the point that clients can perhaps cope or assimilate, right? So they're really sensitive and aware of that. Clients' self-injurious behaviors is another signal that responsive therapists listen to. When clients' threats or when they talk about self-harm, whether it be suicidal or engaging in self-harming behaviors. These negative behaviors may be expressed in the session or out of the session, but therapists are really highly attuned to catching them. And Bedickson McKinley note that this suicidal and self-injurious behavior is very important in dialectical behavior therapy. This kind of behavior structures interventions as well as the treatment protocols. And when they work with their patients, dialectical behavior therapists really are encouraged to strike a balance between being overly restrictive and too accommodating when these kind of behaviors come up. So they really keep an eye on them, and they work within a certain range. They also are markers that assume priority in stage 1 of the treatment approach, and those sorts of behaviors are prioritized over other treatment goals in the therapy. So if they get an indication that a client may be in that state or expressing those kind of feelings, the protocol is changed, and that becomes the focus of treatment. Other negative markers or behaviors that act as signals include client hostility and impatience. And this is clearly illustrated in alliance rupture models. So Eubanks and colleagues, Safran and Muran, have identified this kind of behavior when looking at alliance ruptures and come up with ways of working with it in order to resolve them. Clients' maladaptive blaming and defensive behavior is a signal in attachment-based family therapy with Diamond, and they pay very close attention to family members' distress. And when it's expressed, when this behavior is manifest, they really step back and change course in order to respond to either the ambivalence or the resistance that clients might be expressing in the moment. At these moments of sort of pretty obvious kind of negative behavior, many therapists talk about becoming, and certainly as part of alliance rupture models, more validating. They become more curious, more discovery-oriented with their clients, and really try to kind of get back on the client's page in order to resolve the negative behavior before moving on in the treatment. Okay, the last one was clients' nonverbal behaviors. Clients' nonverbal behaviors are very important signals to therapists across a range of approaches. And of course, it includes things like their clients' facial expressions, their body language, their posture, their vocal quality. So responsive therapists attend to clients' nonverbal behavior to gather information about self states, whether they're happy, sad, disgruntled, to gauge the quality of clients' engagement in the session, whether they're involved or distant and disengaged, and to assess clients' emotional processing capacity. For example, in emotion-focused therapy, therapists listen to clients' vocal quality to assess whether they have access to their inner emotional experience. So clients' nonverbal behavior informs therapists about various interpersonal pulls and expectations that are occurring in the moment. For example, Tishby suggests that relational psychodynamic therapists attend to clients' nonverbal behavior to refine their understanding of the transference or their clients' dissociated self-states, while Silberschutz and Kramer talk about attending to clients' nonverbal behavior to guide their responses to client-specific interpersonal styles, right? Clients' nonverbal behaviors can also evoke feelings and images and sensations in the therapist as that generate ways of interacting to support the client and provide greater insight in the moment, as we saw earlier in the example with the therapist who had the image and recalled the memory of teaching her children to swim. So this concludes the section on client signals. What I want to do at this point, what we wanted to do at this point is one, to come back to you, the audience, and, first check in terms of, do you recognize, do you resonate with these client signals as therapists, as researchers? And two, perhaps it would be wonderful if some of you, in listening to this, have been stimulated maybe to recall an incident that you can remember as a therapist where you might have been more intentionally responsive in the moment, have noted something in your client and did something different than you might have been had you continued with the treatment as usual or a protocol. So we really would like to take a few minutes to hear from you in terms of, one, do you resonate to these signals? Do they, you recognize them, or they not make any sense at all? It's quite possible. Maybe you do something completely different. And can anyone share a moment where they were intentionally responsive? So over to you. And I hope we don't have dead silence.
And I can just add, please speak up in Ukrainian. We do have a translator right here with us.
Thank you, Julie.
There's one person. Go ahead. Go ahead. Go ahead.
Will you?
So can I tell my example with my client? So my client had rather difficult childhood, and she's very restricted. And I remember I told her an example about an elephant who had such small rib and he used to go in circles, and now he's big, but he can't get rid of this role. He still continues going in circles. And she memorized this example very much. Yes.
What a beautiful example. Thank you. So sort of really sort of anchored the therapy as a metaphor and spoke to her, really captured her experience.
Can you ask once more? I didn't understand.
Sorry, it sounds as if that was a beautiful metaphor that really resonated for her and captured her experience and sort of almost became a reference point for the two of you.
Yeah, that's true.
Yeah.
She liked this example. And I even sent her the picture with such illustration.
Right.
To show that she is a big elephant. She has a lot of power and she can do some other things than she used to do.
Wonderful. Okay. So it became her totem animal of sorts. Okay. Uli, you're moderating, right? You're noting who has hands up, and will you do that? Because I can't see everyone on my screen.
Yes, as I said before, please just speak up in Ukrainian. Don't be shy. I'm sure many of you have clinical examples, or maybe you have a question to Jeanne at this point before we turn it over. Don't see everybody either, but there's any comment maybe?
Sure, you have examples.
So we'll have more time at the end, so maybe
well,
if
something comes to mind, right? I'm sure many of you do, and you may just feel blanking now as you think about it, but I'm sure you all have signals that that guide you moment by moment, even if they're not coming to mind right now, right? I mean, remember Uli and Star suggest that we're all doing this all of the time. We have somebody. Yes. Hi.
Доброго дня. Недосконало володію англійською, буду розмовляти українською. Хотіла навести приклад з підлітком, який дуже був небагатослівний, але він, коли уходив, залишив мені назву пісні, каже, я хочу вам дати домашнє завдання, послухати цю пісню. І якби прослухавши цю пісню, фактично це пісня, як його послання до мене, його відповідь, бо сам він небагатослівний. І далі у нас іде спілкування фактично через літературні приклади, через пісні, молодіжну субкультуру. І йому так легше висловлювати свої думки. Дякую.
Oh, thank you very much. So, I mean, that was you very much sort of responding to that person in the moment and trying to find a way to make it easier for them to connect and engage in psychotherapy. Thank you. Anybody else? That's an excellent question. And, different approaches have different ways, I think, of responding at those moments and different techniques. Speaking as an emotion-focused therapist, for me, of course, it is a clear signal to move into providing a lot of empathic validation and affirmation at that time. So I would see that as a signal of emotional vulnerability. And it would be a clear signal, even if I was doing an active intervention, to stop whatever I was doing and attend with empathic responding to that painful emotion in the moment. But there are different ways of attending and working with difficult emotions in the moment, right? Okay, I'm worried. Should we? Thank you so much for sharing some of those examples, everyone. I guess I'm sort of also looking at time and concerned that we need to move on and to Hadas and her presentation. Because I'm looking at time, it's 10 to 6, right? Or was it 10 to 7 your time? 10 to 7 your time, 10 to 6 my time. I'm not going to, I'm going to start the therapist lens, but I'm actually going to be quite quick and not deal with everything so that we can move on to Hadas's section. So
That's
as I said,
fine.
the other category is therapist signals. This is information that typically resides in the therapist and informs their responsiveness moment to moment. So it includes things like their theoretical lens, diagnostic markers, therapist characteristics, as well as their own inner reactions. Now, in terms of therapist theoretical lens, of course, this varies depending on whether they have a more relational focus or they have a more of a the therapist is goal-directed. And I'm not going to necessarily review all of them because I'm sure you come perhaps with a lot of this knowledge already and are able to distill it. But some theoretical people, important theoretical lens is attachment theory. And Hadas will deal with this a little bit more in depth in terms of how it impacts the treatment and how therapists use it. And places, those with a more relational focus, use case formulation, and we've talked silver Silberschatz and Kramer's models, as well as family systems and attachment-based family therapy, who have a more kind of relational focus to enhance interactions between parents and children, as well as narrative, the narrative approach that works within clients' therapeutic zone of proximal development. And of course, emotion-focused therapy has a relational focus. It's one of the principles of the approach. And we too try to work within clients' therapeutic zones of proximal development, especially when we're doing dialogue tasks, and use it as a guide of when to engage in understanding work or emotional processing work. And then, of course, there are the more structured approaches, which include Constantino's context responsive psychotherapy integration, as well as integrative therapy, which is Boswell's approach, which don't use a single model, but use, the principles of change that have been identified by Goldfried, and integrate that with the context responsive psychotherapy integration. So these are the theoretical models that people bring, and of course draw on all this knowledge. And we have DBT with Beddix and McKinley, which of course was a treatment first developed in order to deal with suicidal behavior and borderline personality disorder, but of course has been much more elaborated. Other treatment protocols use diagnostic markers, including personality disorders, to determine what to do in the moment, GAD, depression. So, Kramer makes a distinction between disorder-specific responsiveness versus more generic responsiveness or individualized responsiveness. So some therapists are guided by diagnostic markers and use that to determine what clients, how to act, how to be in the moment, what intervention to use. Okay, at this point, I'm going to turn you over to Hadas, who's going to talk more about therapist characteristics.
Okay, so thank you very much, Jeanne. Yeah, so thank you very much, Jeanne. And like Jeanne said, it's not a comprehensive list, and we will want to think also with you things that you think maybe are missing. And of course, there's some overlap between the client signals, the therapist signals, and the interpersonal signals. And thank you for your beautiful, beautiful examples. We will go back to them. So in terms of therapist characteristics, Hatcher has sort of stated that therapists are more than their techniques. They are persons with distinct personalities, characteristics, and histories. So to be responsive, therapists need to be open and willing to be flexible and to deviate from their course in order to align what they're doing with the client's focus, direction, and goals. So like even in the example that Jeanne gave with the woman and swimming, the therapist was flexible in offering this metaphor, and also with the elephant example. Okay, and then this kind of responsiveness requires the therapist to develop high levels of competence, and like Jeanne mentioned, mastery, and balance with humility so that they allow sufficient space for clients to express their concerns freely and do not make themselves central to the process. So in the beautiful example with the adolescent that you gave, it's really the therapist giving this adolescent space to use music or any other channel that suits them. Another signal is therapist inner reactions. So in the process of attending to their clients, therapists monitor their own reactions, positive and negative. They have to learn to contain these reactions, especially the negative ones are challenging, and how to use them effectively. And with the negative reaction, especially feelings of tension, boredom, sometimes irritation or disconnection can alert them to ruptures. So the responsive therapist manages these negative feelings to repair ruptures and are aware that repair, as Eubanks and Chris Moran suggested, is more than just metacommunication. The therapist really needs to not only talk what is happening here in the session, but really look inside and from their own inner reactions. So both these positive and negative feelings provide feedback to the therapist to choose a technique or to direct their focus of attention in the session. And a therapist needs to be also aware of their own relational patterns to regulate closeness and distance and to attend to how these are impacting the treatment. So this is just briefly to capture the therapist signals. And now I move to the interpersonal signals. With the interpersonal signals, and like I said, there's some overlap, the therapist integrates all the information from the client and therapist signals and works at multiple levels. So the three major clusters of therapist interpersonal signals are alliance ruptures, client feedback, and client diversity and uniqueness. Talking about alliance ruptures, therapists continuously monitor the alliance. As you know, I'm sure you're familiar with Borden's model of alliance, where in order for there to be a working alliance, a positive working alliance, the therapist and the client feels that the therapist and he or she agree on goals, agree on tasks, and there's an emotional bond. But when there's breaks in the collaboration, be it disagreement on the goals or lack of collaboration on tasks is the way we're going to work to achieve our goals, or a strain in the bond, then we have a rupture. So the responsive therapist needs to monitor the alliance, to be aware of what Jeanne mentioned before, the client's therapeutic zone of flexible development, and the client's capacity to engage with the therapist in the treatment approach based on the client's relational and interpersonal map. So clearly in the interpersonal signals, the therapist pays attention to relational maps. And repairing ruptures is really inseparably linked to responsiveness. So responsive therapists are sensitive to moments when their clients are capable or not capable engaging in certain ways, and take account of clients' flexibility, cognitive complexity, and capacity for change and integration. So like you mentioned in one of the examples, the therapist took into account the rigidness of the client, that she wasn't flexible. And mentioned before, attachment theory. And attachment theory is an excellent guide for interpersonal responsiveness. Here we found, and this is work I did with Sharon Ngozi and Oria Tishby, that taking attachment theory and trying to characterize the attachment pattern of both client and therapist helps to understand how the therapist can regulate the appropriate therapeutic distance or closeness in the therapeutic relationship. So here the client, and just a second, the client feels my therapist is too close, yeah, back off a bit. And the therapist feels that the client is too close, too distant, that it's hard to engage the client. And this is what happens when the client has an avoidance style. So in an avoidance style, the client really is hesitant to self-disclose, to reach intimacy with therapists, and wants to keep their self-reliance at all costs. The opposite insecure, or the different kind of insecure attachment, is the anxious attachment. In that case, the client feels that the therapist is too far and they want the therapist to be really, really close to them. And the therapist feels that the client is too sticky and won't keep a distance and is preoccupied with thoughts about abandonment. So what this model really tells us is that to be responsive, the therapist has to adjust to this. So if the client is avoidant and feels the therapist is too close, the therapist has to respect that distance and move really slowly towards greater closeness. In the anxious case, the therapist has to be tolerant and to allow the client to be more dependent and gradually build more autonomy in the client. The second interpersonal signal, and I will go more quickly with that, is the client feedback. So the therapist listens to client feedback and pays attention to the client's response and how they're feeling. And it could be informal feedback, like negative comments, positive comments, or client's agreement with the therapist's direction. It's evidence that the client believes in the treatment, and also formal feedback using measures and outcome indices to get feedback about alliance, about ruptures, about outcome. And Heidi Levitt and Bo suggest seeking feedback from clients in the session. So as you're working with your client, you can say, what is happening inside you when you look at your experience? So we're not waiting for the next session to ask, how was this for you? Or waiting for the client to complete some self-report questionnaire, but we actually ask the client very gently, not intrusively. I thought of an example that I recently experienced with a woman, given the situation in Israel, that you may connect to in terms of Ukraine and the war situation. So this woman was very anxious and very overwhelmed by everything that was happening. And she was trying to not be exposed too much to the media and to hearing about the atrocities, etc. So, but the problem was that she had a 95-year-old mother that when she came to visit her, the mother who just sat and watched TV all day, when this young woman came to, not so young, I guess, if the mother is 95, but when this woman came to visit, then the mother, the elderly woman, the elderly mother, would bombard my client with all these stories about the atrocities, and she heard what happened to this woman, and that I won't go through all the terrible things that happened. And the client was so disturbed by this that she stopped visiting her mother. Like after 3 weeks, her mother called and said, "What's happening? How come you're not visiting me regularly?" So when she told me that, I felt that I also have to be quite cautious with her. But in the sessions, she herself talked about these things and how disturbing they were. So I asked her, what happens to you when we talk about this in the sessions? And she said, no, it's completely different. Like it's here, you listen to me talk about it, and I decide how much to talk about it. And I feel you're with me in these things. Whereas when I come to my mother, the opposite of being responsive is the way her mother is dealing with. But you know, she's 95, so we won't be too harsh with her. Okay, and then just to go briefly through the two other types of signals, client diversity and uniqueness. I think Jeanne already mentioned some of that, and being sensitive to clients' diverse identities and to differences in the power, and also to avoid microaggressions that have to do with race or culture, and making certain assumptions about the client because of their race or cultural or sexual orientation. Okay, and also keeping and expressing cultural humility, that I don't know that much about, let's say, Ukrainian culture, and I want to hear from you, stuff like that. So I think we have time for just a brief vignette, and then I'll ask you, and we'll see if we have time for the training. Okay, so this is a brief vignette from a study that I conducted with Oriat Tishby from the Hebrew University in Jerusalem, where clients and therapists told a research assistant during therapy of meaningful interactions that happened between them and the client, or the client told the narrative about the therapist. So I like this example to try and think, is the therapist being here responsive, and what is the experience like for this client? So we call this, and also in our book, the short dress diet. So here's a young woman, and the therapist, the male therapist says, she told me about a short dress that she bought and liked, but that she wouldn't feel comfortable wearing it because she didn't want people to see, and I didn't understand what she meant. And I asked her for what it was that she didn't want people to see. Then, I hope I'm not talking too fast for the translator. So, then there was silence. Oh, thank you. Then there was silence. Remember, Jeanne mentioned noticing silences. And she started crying really bitterly. It was heartbreaking. I was terribly embarrassed. So we had a question before about crying. Because I thought I'd asked something that I shouldn't have. I really had no clue. We're talking about a dress. Like this male therapist says, what's the big deal, a dress? And he understood that there was something there that really embarrassed her. So I asked if something in my questions was inappropriate or hurtful, and she shook her head, and then she told me that she had some scars on her legs, and that she hadn't told almost anyone about them, but she told me. So I think it was a very special moment because it was as if she laid herself bare in the dress. She told me about the scars as if she was showing them to me. I also felt a kind of gratitude. There was something very intense in that moment, a sense of intimacy. I feel she can expose one of her deepest fears and survive it. She's taking another very big step, and she trusts that I will survive this exposure. So now let's see what the client says. It's an independent interview. She doesn't know what the therapist recounted. And she talks about this dress thing. And she said, one of my great dilemmas was whether to wear a short dress, because that would mean showing my legs, which would reveal a very big weakness of mine, as if I was wearing my wounds on my legs, or scars more exactly. That would be a very big exposure, very much like nakedness. We talked about it in the session, and he really encouraged me to wear it. Yesterday, I came to the session wearing the dress, and when I came to the room, he looked at my dress and said, "You are wearing the dress." And I said, "Yes, I did it." And he understood exactly what that means for me, that it's awfully sensitive. And we talked about what kind of reaction I would like to get from those around me. Because she says that when she bought the dress, the woman at the store said, "It looks great on you, you look so beautiful in it." But she didn't believe the woman at the store because she's just trying to sell this dress. And then her girlfriends, when she tried it on, said, no one can see the scars, you look okay, it's fine. But she says that when they discussed this, she reached the conclusion, reached the conclusion that I want some sort of authentic reaction. I want somebody to come and tell me, you look nice in the dress, or you don't look good in the dress. And then she recalls in this narrative, before I left, he said, "You look nice in the dress." I said, "Thank you, but you're not objective. And she giggles. Then he said, "True." And she said, I left smiling. And she said, "He's so non-judgmental, so accepting, so supportive. He's very understanding. He doesn't get scared. He helps me understand myself, understand the monster, helps me dig deeper into those feelings. I feel great appreciation and gratitude." So now if we can open it up to ask the audience, or if, just a second, I'll go back. What did you think about this vignette? What would you do? What does it bring up for you? Because it doesn't say in any manual that you should say you look nice in the dress.
Mm-hmm.
Again, if you want to comment in Ukrainian, please go ahead. Or
Thank you.
just a comment on this
Sure.
beautiful example. Go ahead with comments. Anybody, please. How you react to this beautiful example.
Yes, please. I see we have a question.
Всім доброї години, вітаю. Дуже приємно знаходитись на такому заході і щось нове дізнатись для себе. Що ж стосується суконьки, то, як на мене, це можливість трохи дозволити клієнту зрозуміти, що ти звичайна людина, і ти розумієш людину, її мову, її вчинки, її настрій. Тобто не бути над людиною, не принижувати людину, не дати знати, що ти знаєш щось більше або можеш робити щось краще, а просто бути поряд. І коли людина якій складно, важко, не дивлячись на те, в яких вона обставинах, завжди приємно розуміти, що біля тебе хтось є, поряд хтось є.
Thank you. Thank you for this beautiful sort of that thinking.
I noticed that it was very important for her to feel some authentic reaction, some true reaction.
Yeah, thank you.
Because we feel so and hear so many false things, and people very often don't mean what they say. And maybe the therapist being authentic and true, it helps the clients to hear him and himself as well.
Yeah, thank you. So, of course, it's very important to keep in mind the stage in therapy. Early on in therapy, it would be a bit dangerous to sort of respond in that way, but and maybe even could be interpreted as intrusive, or the male therapist flirting with this woman. But at the stage of the alliance that they had, that was established, and there is trust between them, and as she says, she doesn't feel he's judgmental. It was like you said, the right kind of closeness, and it was experienced as the appropriate distance or closeness in this case. Yeah. Okay, should I continue and wrap up and then? Okay, thank you. Okay, so just a word about training. So responsiveness is not a matter of being competent in the delivery of specific techniques only. Rather, it's a sensitively choreographed dance that occurs between therapist and client to facilitate positive treatment outcomes. So we can say that in this vignette, the client and therapist really were able to dance in a sensitive way. And as George Silbershach in your previous webinar showed, it's really, instead of training therapists to adopt a specified techniques for patients who share a diagnosis, and Jeanne also emphasized this, therapists need to receive more training in how to be more responsive to their patients' particular problems, goals, and needs or plans, and so forth. So in training for responsiveness, we want the therapist to increase mutual recognition, the emotional attunement in the moment, to manage countertransference. You can think maybe in countertransference terms in the example that I gave, where the client and I are in shared collective sort of trauma environment, and the way probably you in the Ukraine are treating clients within the context of the war in the brain. So you need to manage your own countertransference, and that's very important for training, and to become aware of the attachment styles as I showed, and so forth. I just mentioned briefly that alliance-focused training is a very effective way to deal with increasing responsiveness and dealing with finding the right response within a rupture. And the beauty of alliance-focused training is that you can use it with any orientation. You don't have to use the particularly relational. You can be a Gestalt therapist and also consider alliance-focused when you have rupture and need to repair. And we want to, Jeanne and I, encourage in training the use of process measures. And for example, just to mention Irene Elkin that developed a therapist responsiveness measure that can be very helpful. And finally, using interpersonal process recall, which I find is very helpful with the trainees. You videotape the session and then stop the videotape at various points and inquire the trainee about their intention, thoughts, feelings, what they imagine the client is thinking, and feeling at what one thinks the client is thinking about them. So this is a method that Kagan and Kagan developed for training teachers, and Robert Elliott and Knox and Claire Hill and Remy have advocated using it for psychotherapy and for training as well, Knox and Hill in the chapter in the handbook. So I think we need to sort of close up. So I'll just mention the importance of the responsiveness also of the supervisor. So I don't think I have time so much about the research. Okay, maybe just to say that we need new measures, new methods. We need to take existing process measures and unpack them. For example, if we rate that the client is feeling understood, what is it exactly happening there that they're feeling understood? And to model interactions. You know, today we have very sophisticated studies on synchronization and so forth. So in keeping with the concept of responsiveness, the map of signals that Jeanne and I suggested based on the chapters of our contributors can best be thought as an interactive and evolving as researchers and clinicians continue to discover new routes and ways of adapting and tailoring treatments and techniques for each client's journey, while taking account of changing condition and emerging context. So we encourage researchers and psychotherapists to continue to engage in theory building, unpacking existing measures, developing new measures and methods to accumulate research on how to get it right and to be optimally responsive for the sake of our clients and enhance outcomes. So on behalf of Jeanne and myself, thank you very much to Uli, Michal, for inviting us to take part in this important SPR Ukrainian initiative, and to the contributors of our book, and to you, the webinar audience. And we're happy to answer or hear a few more comments if, or to hear Uli, whatever the moderators feel is appropriate. Thank you.
Thank you so much for your wise words, both of you. There may be time for one comment or questions before we close. That's okay for you? Yeah? Any reactions? How do you respond? There are some comments which unfortunately I cannot read. Maybe Okay, there's one person. Yes, please go ahead. Excuse me. So that
We
wasn't
had
the
a
hand.
hand there.
Якщо можна, я швиденько розкажу про антиприклад нечуйності. Я була тоді в ролі клієнта у психотерапевта, і коли я розповідала про свою проблему, психотерапевт розсміявся і дуже голосно, і це буквально розірвало наш альянс просто і розірвало всі наші стосунки, тому що в той момент мені потрібна була інша реакція. Це я з ролі клієнта говорю про те, як дійсно дуже важливо бути гнучким і чутливим в момент терапії. Дякую вам за таку чудову лекцію. Це просто неймовірно, неймовірний досвід.
Thank you. I just want to say about the last comment that we can learn somewhat painfully about responsiveness through examples like the one you gave, where therapists are being not responsive or responding in a hurtful and not the right response in the right time. Jeanne, maybe you want to add to that.
I think it's the one, it is absolutely, is identifying those moments of when therapists are not responsive in psychotherapy and studying and researching those. So it's a lovely example, and I'm really sorry that you had to be the recipient. So, but thank you for sharing how important it is to get you the moment.
Well, it is now my moment before I turn it over to my colleague Michal to express my gratitude really to Hadas Wiseman and Jeanne Watson for opening your beautiful book you talked about, for opening your hearts with your very meaningful examples. And I think this group has been also responded already by all many thank yous, and there will be more to come. So thank you for doing this evening. It's been very meaningful. And I very much look forward to a next webinar we will be having within this initiative. Michal, are you here?
Yes, I am.
Yes, I'll let you close the webinar. Thank you, everyone.
Thank you. So, first of all, thank you, Jeanne. Thank you, Hadas, once again for bringing this beautiful part of psychotherapy knowledge and sharing it with us. I actually was inspired also by it, and would like to say that there was this Professor Antoni Kępiński here in Krakow, and he identified several errors, several mistakes a psychotherapist can make, and one of those mistakes was the error of mask. And I think that the error of mask is actually something that is in opposition to responsiveness. So you should be responsive in order really to build a therapeutic alliance with your patient. I think this is crucial. So thank you for sharing this and also for bringing this knowledge to us. Thank you, Katarina, for your wonderful work on this and on helping us to organize this and on bringing us together. This is very, very important. Anastasia, thank you for being a perfect translator, prepared always and always keeping up with what we are saying. So thank you for that. And now I will send you in the chat the dates of the next SPR events. And I have to say that I am proud that some of our Ukrainian friends, Larissa Didaskoya and Natalia Turbovets, will be joining us in Ottawa for a structured discussion that Uli, together with me, we organize, and also Jeanne and Hadas will participate together with George Silberschatz, and we will have a wonderful talk on how Ukrainian psychotherapy research, what we can learn from you and what you can learn from us. So I hope we will have a very nice opportunity to share this knowledge in Ottawa, in Canada. But then please do keep in mind that there is another conference closer in Brno, which will take place in September. And of course, as the local host, I'm very, very proud to also invite you to Krakow in 2025 in June for the international SPR meeting. So thank you to all of you for being here, and of course, good luck with all your difficulties, and you are not alone. We are with you.
Yeah, thank you very much, and we are with you.
Thank you, everyone. We really appreciate you being here with us this evening. Take care.
Take care. Thank you so much.
Thank you. Goodbye. Thank you so much. Should we stay on another minute or two, or?